Let's start, guys. 68-year-old man with 40-year pack history presents with persistent cough, hyponatremia, low serum osmolality, concentrated urine. CT shows a central mass. Which lung cancer is most likely? Any answers? 68-year-old looks like some paraneoplastic syndrome, right? With sodium low, low serum osmolality, concentrated urine. Is it adeno? Okay, let's go to the answer. It's a small cell lung cancer. Okay. In the malignancy of the lung, there are a lot of paraneoplastic syndromes. So you have to remember which kind of lung cancer causes which kind of paraneoplastic syndromes. So this is a small cell lung cancer. It's hyponatremia with low osmolality is most likely a syndrome of inappropriate antidiuretic hormone secretion. Okay, it's mostly associated with small cell lung carcinoma. Okay, just a small um, distribution of the cancers and the lung cancers where they present. Okay, so many of the times in the question they will be mentioning location of the cancer. So according to that also you can guess and accordingly you can answer the questions. So generally, squamous and small cell carcinomas are centrally located, and adenocarcinomas or large or undifferentiated carcinomas mostly are peripherally located. Okay. I have a prepared slide for different types of cancer and their respective paraneoplastic syndrome. All right. Let's move, guys. Okay. A 72-year-old smoker presents with hypercalcemia, low PTH, and cavitating mass in the upper lobe. What is the most likely diagnosis? Hmm? So here you have to diagnose the type of the cancer and associated which kind of complication or associated paraneoplastic syndrome is present. Can it be adenocarcinoma? Generally, no. Could be squamous, could be small cell, one of the two, right? Mesothelioma carcinoma doesn't fit in the picture. But what is the clue? There's a PTH is low, correct? Which type of cancer secretes parathyroid hormone? Hmm? Okay. Yeah. So it's squamous cell, right? High calcium with low PTH suggests parathyroid hormone related secretion, classically seen in squamous cell carcinoma. Okay. This PTH related peptide will generally then, because it's a different chemical or hormone, but the endogenous PTH will be decreased because calcium goes up, right? So don't get confused here. Okay, you might say that because of the bony mets calcium has gone up. It is possible, right? If you see the question, just bony metastasis also can cause high calcium, right? But PTH is low, so most likely squamous cell carcinoma with PTH related peptide secretion. Okay, mostly centrally located and cavitating carcinoma. A 58-year-old woman has sudden right arm weakness, ptosis, anhidrosis. CT shows an apical lung mass. Which structure is most likely involved?
Sympathetic chain.
Sympathetic chain. Yeah, what is the diagnosis here? Right arm weakness, ptosis, anhidrosis, apical lung mass. It's a Horner syndrome, okay, causing obstruction or damage to the sympathetic chain. Ptosis, meiosis, and hydrosis is a classical of Horner syndrome. This can also be caused by, means, of course, apical syndrome. Okay, Pankos tumor. They more or less all are same. A patient with metastatic lung cancer develops confusion, polyuria, polydipsia. Lab shows sodium 150, serum osmolality high, urine osmolarity low. What is the cause? What is diagnosis? What patient is developing? Confusion, polyuria, polydipsia. Yeah. Yes. No. Yeah, we told the phone. Then telling them no. I will order. I'm taking. Okay. Is it first SIDH from SCLC? Small cell? No, it's not SIDH, right? What is the diagnosis? Okay. Somebody answer, I think. C. A is wrong. Hypercalcemia is wrong. Diabetes insipidus from brain metastasis? Yes, possible. Renal tubular acidosis? No. Paraneoplastic acidic secretion? No. So it is diabetes insipidus. Okay. So DI from the brain mets. High sodium, high serum osmolality, very dilute urine, and often from pituitary metastasis. What is the diagnosis? What is the single best test to diagnose diabetes insipidus? I think we have taken class on DI. No, I think no. I think electrolytes. I'm not remembering. Yeah. What do you measure in urine to diagnose DI? Okay, specific gravity. Okay, low specific gravity is the most diagnostic of diabetes insipidus. Okay, and respond to desmopressin or vasopressin. A lung nodule biopsy shows mucin producing glands and TTF1 positivity. What is the diagnosis? Would be very easy. Hmm. It's very classical, okay? So no need to for a confusion. Yes, adenocarcinoma. So thyroid transcription factor positive plus mucin gland is a hallmark of adenocarcinoma. So these are the types of carcinoma and their location, and accordingly some endocrine complications or paraneoplastic complications I have mentioned. Okay. The most common you can see clearly is around squamous cell carcinoma, central, and it has a best prognosis, right? It causes ectopic parathyroid hormone related peptide secretion, ectopic TSH secretion, okay, and hypercalcemia due to bony mates. So hyperthyroidism, hypercalcemia due to PTH or hypercalcemia due to mates. So hypercalcemia equivalent to squamous cell. Don't get confused. Confused, okay? Um, Small cell again. After adeno, it is the third most common. Again, it's central, rapidly progressive, but fortunately sensitive to chemo and radiotherapy. By the time small cell is diagnosed, patient is already has metastasis. So it is very late diagnosed, but sensitive to chemo and radiotherapy. Okay. So all just 1 second, guys. Hello, Dr. Avis. Good evening. I'm good. Oh my God. Yes, I'm as well. I was suggesting that to make a pool of doctors, so many MBBS doctors outside. Yeah. Doctor, I'm just taking one class. I'll call you after 1 hour. Okay. Okay. Yeah. Thank you. Okay. So back again. Yeah. Small cell, 20%, rapidly progressive. So Cushing's, SIDH, Lambert-Eaton, you know, these kind of complications are more in small cell. Okay. Then adenocarcinoma 30%, common in non-smokers. Again, in non-smoker women also, which is common. Other complications which can be recognized is gynecomastia. Although gynecomastia can be present in squamous cell also, but it is more common in adenocarcinoma. And of course, hypertrophic pulmonary osteoarthropathy, which is classical of adenocarcinoma. Other two are undifferentiated large cell carcinoma or bronchoalveolar carcinoma. There's not much discussion about this. More or less questions comes on these paraneoplastic syndromes. Okay. Coming here for this briefly treatment also we can discuss. So cancer generally clubbed together like non-small cell lung cancer, NCLC, and small cell lung cancer. So generally non-small cell lung cancer, stage 1 and stage 2, chance surgery, and after that chemotherapy or immunotherapy. And after stage 2 is generally chemotherapy or molecular therapy. Okay. Small cell is always chemo plus radiotherapy or immunotherapy, because by the time small cell is diagnosed, is already metastasized. Some more questions. A 70-year-old man with lung cancer developed ptosis, meiosis. Again, repeat question. But which tumor location is most likely? Very straightforward. So Pankos tumor, apical tumor, superior sulcus tumor causing Horner's is very common. Okay. So answer is apical tumor, Pankos tumor. Which lung cancer subtypes is most strongly associated with rapid early metastasis and paraneoplastic ACTH secretion? We just
Small
discussed,
cell.
right? Small cell, so causing Cushing disease or Cushing.
Yes.
Okay. A 59-year-old man with small cell lung cancer developed widespread bone mets and liver mets. What is the standard first line treatment? Are there many questions on treatment of lung cancer? I don't think much, right? That's why I did not include many questions on the cancer treatment. Anyway, so let's go back to this question. Small cell lung cancer, widespread bone mets, liver mets. What is the standard first line treatment?
Chemo, platinum resection.
No, section already is there. Widespread bony mets are there, no? And plus small cell lung cancer. Surgery is never an option. Okay. So answer is C.
Platinum.
Okay. Platinum based plus etoposide plus immunotherapy is always systematic at presentation. So chemo is the first choice, the first treatment. Okay. After that, maybe immunotherapy or radiotherapy is possible. These are the common patterns. I don't know, they ask much on the MRCP1, maybe more. So, immunohistochemistry pattern in different kinds of cancers, you can notice. So, adenocarcinoma, which we already discussed, is thyroid transcription factor 1. Okay, that is mostly present. Mucin, napsin A, SURF-A, SURF-B, PAS-Ds, and cytokeratin. So I think TTF1 you can remember, mucin you can remember, cytokeratin CK7 you can remember, Okay, because others are negative, and it is negative for thyroglobulin. Where was the TSH secretion? Which one was? It was squamous cell, TSH secreting tumor. Okay. In squamous cell, common mutation P40, P63, CK56, but usually negative for CK7. Adenosquamous or adenocarcinoma, generally you have to differentiate from adenocarcinoma of the other regions. Like it could be mates from CA colon of adenocarcinoma or CA breast cancer. So combination of patterns can be present in adeno and squamous cell carcinoma. Poorly differentiated or mates from other, again you have to differentiate from the other cancers which metastasize to lung, like I discussed already, adenocarcinoma from the lung, or adenocarcinoma from the breast. Okay. And small cell, coming to small cell lung cancer, although adenocarcinoma also TTF1 positive, small cell lung cancer can also be TTF1 positive. Okay.
Okay.
Uh, But more importantly, high proliferative rate of Ki67 and MIB1, and the remaining like CD56, chromoganin, or neuron specific enolase. Okay. These can be the factors you can find on immunohistochemistry pattern of the different cancers. This generally is useful to target the targeted therapy or molecular therapy. So these are the molecular targets in non-small cell lung cancer, as we discussed already. Okay, mostly molecular targets in this non-small cell. Small cell is chemotherapy and radiotherapy. Okay, the common ones, if you find treatment, is mTOR inhibition or EGFR inhibition, targeting EGFR. If you want to take a picture, you can take, but I think I just kept it to so you can understand where the pathogenesis of the different genes and mutations can happen. So common is EGFR mutation. Generally, the target mTOR. There is a target. These are generally in, I think, CA breast, okay, but can be in non-small cell lung cancer. These are the general molecular targets in non-small cell lung cancer. Which mutation is most commonly seen in non-smoking Asian women with adenocarcinoma of the lung? Just now we discussed, okay? So EGFR is the most common mutation. So that's why it is this mutation leads to adenocarcinoma even in non-smoking people, mostly Asian women. And even though in general adenocarcinoma is common in non-smoker and other squamous and small cell are common in smoking smokers. A 48-year-old non-smoker presents with recurrent pneumonia in the same segment of the right lung. CT shows a well circumscribed endobronchial mass with intense enhancement. Bronchoscopy reveals a pink vascular lesion. Biopsy shows a uniform cells, salt and paper chromatin, and Ki67 of 2%. What is the most appropriate next step in the management? So you have to diagnose the condition of the cancer, and you have to uh, give the answer of the treatment. What is the best step in the management? What do you think this is? What kind of cancer it is? Is it our typical cancer, lung cancer? B. Lobectomy with lymph node sampling. What is the diagnosis here? Okay, so it is a typical carcinoid tumor. Okay, treatment is always curative treatment is always surgical. Okay, so what are the options here? Start octreotide? No, this is for metastasis or when the carcinoid syndrome is present. We have no clue here that it has mentioned he has all diarrhea, loose motions, or respiratory issues. Okay, so octreotide can be option if those symptoms are given. Lobectomy with lymph node sampling is the best one. Is a well circumscribed lesion, easily can be removed with the lobectomy. Again, chemotherapy cisplatin etoposide goes towards again squamous cell treatment. Radiotherapy for small cell. Endobronchial laser ablation, no. If bleeding or something, maybe it will worsen it. We will never do endobronchial ablation for carcinoid tumor. Okay, so the option is lobectomy with lymph node sampling. This is a typical carcinoid tumor, Ki-16 less than 3%, uniform cells. Localized disease is treated with surgical resection, okay, or a bronchoscopy alone. Octreotide is for carcinoid or metastatic disease. Chemotherapy and radiotherapy are not a first line for localized typical carcinoid. A 67-year-old former shipyard worker presents with dyspnea and dull chest pain. A chest X-ray shows a unilateral pleural effusion. Thoracoscopy reveals diffuse pleural thickening encasing the lung. Histology shows asbestos bodies and calretinine positive staining. Which treatment provides survival benefit? Fluorodesis? No, it's a palliative. Tall drainage? No, again, only when he has effusion and on fluorodesis. Iodosteroid? No. Radiotherapy alone? No. So simple answer, cisplatin and pemetrexed is the treatment of choice for mesothelioma. Okay. So this is a malignant pleural mesothelioma. Only proven systemic therapy benefit is pemetrexed and cisplatin. Fluorodesis and drainage improve symptoms but not survival. Radiotherapy alone does not improve outcomes. Mesothelioma is a very bad prognostic tumor. A 12-year-old woman is found to have a solitary pulmonary nodule on CT scan. The lesion contains popcorn calcification and islands of fat. She is otherwise well. What is the most appropriate management? Surgical excision, you go for a PET scan, you go for do nothing, you go to bronchoscopy with biopsy or a radiotherapy. What is this tumor? It's a classic presentation, popcorn classification, calcification with islands of fat, serial CT surveillance. Okay. Yes, it's a classic hematoma. It's a popcorn classification, intralesional fat deposition. Okay. These are benign, slow-growing tumors. If asymptomatic and radiologically typical, no biopsy or surgery is needed. Serial CT scans every 6 months or annually is enough to confirm stability or worsening. A 33-year-old woman presents with progressive dyspnea. CT chest shows multiple thin-walled cysts throughout the lung. She has a history of renal angiomyolipoma. VEGF-D levels are elevated. What is the best disease-modifying treatment? Any clue? Methotrexate generally for rheumatological diseases. Steroids also for rheumatological diseases. Sirolimus, not sure. Cyclophosphamide again goes to Immunology, lung radiotherapy, maybe. Let's see. We should know the diagnosis first, then answer becomes easy. Okay. Sorry, guys. Okay, the answer is sirolimus. It is LAM actually. Lymphangioliomyomatosis is a rare cystic lung disease associated with tuberous sclerosis and angiomyolipomas. Benign tumor, all are benign. Okay, this vascular endothelial growth factor D helps to confirm the diagnosis. Sirolimus, the mTOR inhibitor, slows declining lung function and reduces angiomyolipoma size. Steroids, immunosuppression do not help, and radiotherapy is contraindicated. Okay. So mostly benign cystic diseases, but to prevent the lung function deterioration, sirolimus can be tried. Other has no role in management. Okay. So if you see, so multiple thin wall cyst, if they have given some additional history like renal angiomyolipoma, consider as LAM, okay, and as a part of tuberous sclerosis, and sirolimus is the treatment of choice. A 46-year-old non-smoker woman presents with recurrent pneumonia in the same segment of the right middle lobe. CT shows a well-defined endobronchial mass with intense enhancement after contrast. Serum chromogranin A is elevated. What is the most appropriate next step? 46 non-smoker, recurrent pneumonia, same segment. CT shows well-defined mass, endobronchial mass, intense enhancement with chromogranin A elevated. What is the most appropriate next step? Endobronchial biopsy during bronchoscopy? Maybe. Surgical lobectomy? Possible. Octreotide scan? No need. PET FDG scan? I think no need. Or sarsomatostatin? Oh, sorry. Okay. So surgical lobectomy is the answer. It's again a carcinoid. Okay. So carcinoid, always surgical is a treatment. Central enhancing tumor, typical carcinoid, bleeds heavily in biopsies. So biopsy is very risky. If it is very clear, no need. Lobectomy or tumourectomy is good enough. Definitive treatment, surgical resection, lobectomy, curative in most cases. FDG PET scan has low sensitivity. Octreotide again is for treatment, symptomatic treatment, not the first step. Again, so metastatin unlocks same as octreotide only for unresectable metastatic disease to control the symptoms. A 55-year-old woman, lifelong non-smoker, has chronic dry cough and dyspnea. HRCT shows mosaic attenuation and multiple tiny pulmonary nodules. Lung function even reduced with air trapping. What diagnosis best fits this presentation? 55, non-smoker, has chronic dry cough, dyspnea, mosaic pattern, multiple tiny pulmonary nodules. Myomatosis? No, no. Pulmonary metastasis? Possible, but other symptoms doesn't go. Hypersensitive pneumonitis? No, no. What is deep neck sarcoidosis? Any? Oh God. Okay. So answer is diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. Okay. The clue is middle-aged woman, non-smoker, and mosaic pattern with numerous tiny nodules. Okay, and it can cause from obstructive to restrictive lesions as well. So constrictive bronchiolitis is possible. Can coexist with typical carcinoid tumor also. So it's a deep neck, diffuse idiopathic pulmonary neuroendocrine, middle-aged non-smoker woman with mosaic pattern. So you can remember these different patterns, guys. Okay, here it is mosaic pattern for small nodules for the deep neck. Carcinoid generally endobronchial near the endobronchus, well circumcised. Enhancement is there easily. Okay. Um, then lamb will show multiple thin wall cyst, some other history with congenital issues like tuberous sclerosis, something. Okay, hematoma or popcorn classification with interlesional fat, nothing to be done unless causing symptoms. Just follow up. Okay, so these are some different kinds of tumors can present. So have to remember. Okay. A 62-year-old man presents with chronic cough and weight loss. CT chest shows a large air bronchogram containing consolidation in the left upper lobe persistent over 3 months. Bronchoscopy is non-diagnostic. PET CT shows a mild moderate uptake. What is the most likely diagnosis? Adenocarcinoma, generally peripheral, possible. Primary pulmonary lymphoma, MALT, organizing pneumonia. While discussing cancer, it has to be some cancer. Metastatic disease, possible. Atypical infection, no. Any option, guys? Odd one out, it is MALT. Okay. Primary pulmonary lymphoma. Features favoring MALT are persistent lobar consolidation, air bronchogram within the tumor, PET SUV usually modest, not too much uptake in lymphoma. Often non-diagnostic bronchoscopy requires surgical biopsy. Okay, bronchoscopic biopsy may not be enough to diagnose. Slow growing with consolidation, with air bronchogram, with less PET uptake. Okay, B symptoms can be present. Okay. Again, adenocarcinoma also could be consolidated, but PET uptake can be variable. Chronicity and limited bronchoscopic yield point to the lymphoma. Okay. So some classical find features are there which you can distinguish primary pulmonary lymphoma from others. A 39-year-old woman presents with wheeze, hemoptysis, and stridor. CT shows a smooth, low-grade appearing mass arising from the tracheal posterior wall. PET CT shows a minimal FDG uptake. What is the most likely diagnosis? 39, wheeze, hemoptysis, stridor. CT shows a smooth, low-grade appearing mass arising from the tracheal posterior wall. 8 CT shows minimal uptake. What is the most likely diagnosis? Squamous cell carcinoma, unlikely. Why? V is hemoptysis started low grade from the tracheal posterior wall. No uptake, much uptake. So unlikely. The squamous small cell is unlikely. Thyroid carcinoma invasion, yes, possible. Tracheal papillomatosis, no. So answer is C, adenoid cystic carcinoma. So it's a low-grade salivary gland type tumor. Occurs in the trachea or the main bronchi. That was the clue. Smooth contour, minimal of FDG uptake. Again, the lymphoma also less uptake. This adenoid cystic carcinoma also less uptake. Causes V stridor or airway obstruction because it's in the main trachea or the bronchi. Local invasion common, metastasis uncommon. Squamous cell carcinoma more aggressive and FDG avid, so it will have a lot of uptake on the PET scan. Okay, I think not much today. This was all today, guys. Not much time to prepare today. Last week was very busy. Any questions? Any doubts? I tried to cover the questions which can come, and you can at least you can know the topics, and then you can do a little bit more reading on each type of. But I think other kinds of are not required. Just have a look on the treatment options. Any particular, if you find many questions on molecular therapy or molecular targets, so those you can maybe have to think about it. But otherwise, lung tumors, this is, I think, good enough topic to cover most of the lung cancers. Any questions, guys? Today we'll close it here, conclude here. Okay, guys, we'll close. Class 1 and 2 topic were covered. I think we covered COPD, asthma, and lung infections were covered in the last two classes. There are a lot to cover in respiratory disease, but they are part and parcel of some other disease like vasculitis. It comes in rheumatoid also. What are the topics? Other topics are there in respiratory we'll cover. So in the respiratory, there are topics which are pending now. Lung anatomy and physiology. Disease of the lungs we have done. Lung infections done. Occupational lung diseases more or less done. Tumors done. Yeah, so interstitial lung disease, there's not much on that. Then vasculitis and miscellaneous. So I think in one or two classes we can conclude for respiratory. You want anatomy physiology on the lung, or we can skip that one? Okay, guys. Then thank you for joining. See you next time, guys.